Now I'd like to present Dr. Gamal Hosny to carry on his great experience with the congenital pseudoarthrosis of the tibia. Carry on, Dr. Gamal. Thank you very much.
Thanks, Dr. Saleh, and thanks, Dr. Fraz, for chairing this session. And now we've listened to 2 lectures about congenital pseudoarthrosis tibia, and I'm not going to repeat the informations mentioned in these 2 papers. I want to remind you, I got this notes now that the deformity correction, how deformity correction will be held 26 June 2021, hopefully. No. So I've listened to them, and I think I had 2 problems. The prophylactic treatment, because Professor Joe said that prophylactic treatment has to be conservative by bracing, and the refracture in atrophic type is 50%. So I'm going to concentrate in these 2 issues. Forget about all the other issues. I'm not going to discuss them. Let us concentrate on the prophylactic treatment. Do we have to do it just for bracing? Because the people in our area, I don't know, that Saleh also will tell you, they don't like the braces. And usually they don't follow the rules that they have to put a brace till the skeletal maturity. Can you imagine the guy at the age 12 and putting a brace the whole day or something? It's a bit difficult. Also, the refracture rate is about 50% with the reserve treatment. It's a successful treatment, we know. As a primary treatment, we have healing of 100% of cases, but we have 50% refractures in the atrophic type. So again, if you look at the treatment, you have prophylactic treatment and surgical treatment. And we're going to start with prophylactic treatment. We all know that we have a pre-pseudoarthrosis stage, which is anterolateral bowing with neurofibromatosis 1. And this is an example of anterolateral bowing in children. And this is an example of this child. This is female, and she had a neurofibromatosis with anterolateral bowing, and this is the father. You see the neurofibromatosis. So, you know, why do you advise the people to wait with such a deformity? And we all know that we alter the stress-strain distribution, because bowing of the long bones likely results in altered stress-strain distribution, or potentially increases the risk of the fracture. So if you leave the deformity, and it's really a precursor of congenital pseudoarthrosis tibia, it looks like you are inviting for a fracture. And if you do an osteotomy, like Professor Shu said, that if you do an osteotomy at the area of anterolateral bowing, this is the end up. You are going to end up with pseudoarthrosis, whatever you do. Nailing, plating, vascularized fibrillar graft, or Elizarov. In each case, you are going to end up with the pseudoarthrosis. So do you advise the people to wait till the older age? So if there is a necessity to do prophylactic treatment, some people, they think that you have to do bracing to the skeletal maturity, or bypass grafting, or radical resection of this part, or guided growth. And I had this patient. So each year the patient comes, and I tell the family and the grandmother, she has to wait, she has to wait, she has to wait, she has to wait. And finally she told me, do I come to you for 6 years? And you just tell me every year, wait and put the patient in place. Why do I come to you? She's right. So do we have to wait till his skeletal maturity? You know that if you have asymmetrical distribution of the forces, I'm sure that you have disturbance of the growth plate. So it's not a benign thing to wait till the end of the skeletal growth. Besides, if you wait till adolescence, you have social anxiety, embarrassment, feeling of, you have problems. If you wait till, so you have psychological problems. So the deformity, if you leave the deformity to skeletal maturity, you are going to have serious social and psychological effects. So we thought about prophylactic treatment. This is the single case of guided growth. But you see, he didn't correct the deformity actually. The hypothesis that this deformity is in the oblique plane, you see in the AP and lateral. And it is C-shaped deformity. So if you want to correct it, we do an osteotomy above the zone of irregularity and another osteotomy below the zone of irregularity. So we avoid the deceased bone. So we do an osteotomy in the healthy bone and another osteotomy in the healthy bone. C-shaped deformity. And as you see, we have a third line. So we do an osteotomy above the first cora or the first apex, another osteotomy below. You see, we have two osteotomies, and we corrected the deformity by two osteotomies, and we leave this diseased part. We leave it. And you see with the follow-up, recanalization of this part. So we prevent the fracture by correcting the deformity. Again, in this case with neurofibromatosis 1, and she had shortening also. And we consider a C-shaped deformity, so we did osteotomy in the healthy bone, another osteotomy in the healthy bone, and we did gradual correction and lengthening. And we left the diseased part because the hypothesis is that if you do axial compression in the proper axial alignment, this will do remodeling of this part. So look here. And this is after correction. But still we have residual valgus. So when you put, after this correction, bifocal correction, we still have residual valgus. So we thought it is physial, so we did 8 plates. But look to the recanalization of this segment. So we believe in early correction of the anterolateral tibial bowing in children with neurofibromatosis 1 with bifocal osteotomies above and below the dysplastic part, followed by gradual differential distraction, which can prevent the development of congenital pseudoarthrosis. Our experience now is 11 cases, and none of them had developed congenital pseudoarthrosis. Again, look to the surgical dilemma. Is it one entity? I'm going to talk about the atrophic type. The atrophic type, you have a marked deformity, you have technical difficulty, very small distal fragment, scars from previous operations, severe osteoporosis, shortening, high refracture rate, which is about 50%. And look to this patient who had 13 previous operations, shortening 17 centimeters. And so I talked about the family asked for amputation. None of our families will ask for amputation. The families in the Arabic area, they refuse amputation totally, so forget about it. It's not a solution in this area. Again, scars from the previous operations, and you have to use the same scar to care. Otherwise, you will have problems with the skin. Marked deformity, 90 degrees deformity. Severe osteoporosis, the patient stayed in a cast and after 5 previous operations for 3 years. Technical difficulty, very difficult. You have 2 previous free vascularized fibrillary. 2 free, and the patient is 4 years old. Again, hardware removal. You have to remove all this hardware. Sometimes you've got limited options because of the failure of the free vascularized fibrillary. Free vascularized fibrillary is a good operation, but you have limited options left if you have failure like this one. I'm going to go through the refracture. We have 29 cases with refractures, all atrophic type. They are all, this is a single author experience. You know, I've never had a virgin case. All my cases had been treated before elsewhere. So we know that the primary union is easy to resolve. But the problem with the refractures, because of to my mind, there are cross-sectional area, the removal of the intramedullary road, and the residual valgus deformity. And I'll give you an example how do I manage with the refracture. This case had been treated by bone transport before, and this is the end result. and a very small segment. And we had another refracture. We had 2 refractures with reserve. And we did bone transport. During removal of the, we put multiple K wires that is from retrograde from the heel, multiple, 4 or 5. Then we put the patient in the cast and we leave this area. So the patient can do full weight bearing with about 3 centimeter cast from the behind and on the forefoot. So the patient can put full weight bearing and we leave these wires. We believe that these multiple wires can stimulate again the union in the area of pseudoarthrosis. Then we change the cast after 1.5 months, and after another 1 month, we remove the wires. Putting retrograde the wires and removing them increase the bone formation after the removal. So distraction, histogenesis, retrograde application of the wires, and removal of the wires. And you see with the follow-up. Complete consolidation with no refractures. Now, and this is case of failure of free vascularized graft with very small segment. Again, bone transport. There is no problem with the bone transport, and this is not the issue. See very small fragments, union. But the problem here is with the axial alignment. He has a valgus deformity, axial malalignment. You see, this is the way, this is an arrow to increase the cross-sectional area of healing. And then you correct the axial malalignment. It's very important to correct the axial malalignment to prevent the development of refracture. And you see with the follow-up. This is the last example. This is an atrophic type neurofibromatosis 1, which was treated by free vascularized fibrillar graft. The fibrillar graft was taken from the other side, from the same side. So there was 2 times free vascularized fibrillar graft for such a patient. And she was prepared for the 3rd time. They were planning to take a free vascularized fibrillar graft from the mother. You see how the people are dogmatic because they decided, because they have one option, free vascularized graft. So they did twice from the other side, from the first side, from the ipsilateral side, and they were planning to have a 3rd time from the mother. Anyhow, this was the picture. She came to me, the patient came to me with age 4, and this was the incision on the healthy side. And so we just have the physis and you see the shortening, the 6-year-old boy. Very small fragments. And the patient has physial distraction from this area. You see the physial distraction for 10 centimeters. Physial distraction and lengthening. It's okay. The patient fell to the ground after 2 months and he had a refracture. You see. And the patient waited for 1 year. He came to us after 1 year. There is almost nothing here. We did corticotomy, bone transport. For 12 centimeters, bone transport. Again, the patient has physial distraction for 10 centimeters, and we did bone transport. Then during removal, we apply 5 wires. 5 wires, retrograde. And we put the patient on a cast for 1.5 months. Then we change the cast, then we remove the cast and have an X-ray. Then we put another cast for 2 months. In the cast, we remove the wires. We think introducing the 5 wires and removing the wires will stimulate the bone formation in this area. You see the bone length and equality, it's the same length. And you see the bone formation. Look to the skin and the bone formation. In conclusion, prophylactic surgical treatment of anterolateral bowing bifocal corticotomy is justified to correct the deformity and prevent the development of pseudoarthrosis. Distraction histogenesis, maximum cortical contact, correction of axial malalignment, stimulation of bone formation by multiple wires during fixator removal and casting for 4 months and full weight bearing can prevent the development of refractures. Thank you.
Thank you very much, Dr. Gamal, for this great lecture and very nice cases.